Welcome back. So, in this second part of our deep dive into bipolar II disorder, we're going to get into the really complex clinical challenges and, importantly, the evidence-based ways to manage it. All of this is based on that state-of-the-art review from World Psychiatry.
Okay, so here's what we've got on deck. We'll start by looking at the huge burden of conditions that come along with bipolar II. Then we'll shift to the serious risks involved. After that, we'll get into the nitty-gritty of treatment, both the principles and the specifics. And to wrap it all up, we'll pull together the most important takeaways.
All right, first things first, we have to start with a concept that's absolutely fundamental to understanding bipolar II. Comorbidity isn't just common, it's pretty much the rule. And this, as you can imagine, makes both diagnosis and treatment incredibly complicated.
So check this out. Data from the World's Mental Health Survey gives us this really stark number, 83%. That's how many people with bipolar II have at least one other psychiatric diagnosis alongside it. Just let that sink in for a moment. And the data just keeps painting a more complex picture. It's not just that most patients have a comorbidity. More than half of them are dealing with 3 or more. And get this, a systematic review found that the rate of these co-occurring disorders is almost 30% higher in bipolar II than it is in bipolar I. That's a huge difference. So what are these co-diagnoses? Well, the two biggest ones by far are anxiety and substance use disorders. Anxiety disorders, they show up in about 75% of patients. And they're not just there. They often pop up before the mood episodes and are linked to making treatment tougher and increasing suicide risk. Then you have substance use disorders, which affect about half of all patients. This really complicates things because they can mimic or even trigger mood episodes.
And this isn't just about mental health. The impact of bipolar II is truly systemic. It affects the entire body. We're talking about a 3-fold increased risk of metabolic syndrome. More than 20% of patients are dealing with autoimmune thyroiditis. And the biggest one, cardiovascular disease. It's the leading cause of premature death, and it can shorten life expectancy by a decade, sometimes even more.
So, as you can probably guess, this high rate of comorbidity creates a lot of confusion when it comes to diagnosis. And that confusion, tragically, is directly linked to an elevated risk of suicide.
Yeah, telling bipolar II disorder apart from other conditions like borderline personality disorder or even ADHD can be a real clinical challenge. You've got overlapping symptoms like impulsivity and mood swings. So what's the key difference? It really comes down to looking for the episodic nature of mood changes in BD2 compared to the more constant long-term patterns you see in personality disorders.
You know, there's this common misconception that bipolar II is somehow a milder version of the disorder. Well, the data says otherwise. When it comes to suicide risk, it's just as severe as bipolar I, and maybe even higher. In fact, several studies point to more suicide attempts and completed suicides in bipolar II. 1/3, 33%. That's how many individuals with bipolar II report having attempted suicide at some point in their lives. It's a number that just hammers home how lethal this disorder can be. So what this all really boils down to is that getting a diagnosis right and getting it quickly isn't just about starting treatment. It's about immediate, life-saving risk management. That first year after diagnosis is the highest risk period, which just highlights how absolutely urgent it is to intervene. Okay, so we've laid out the challenges. The question now is, how do clinicians actually approach treatment? Well, it starts with admitting something important. There's a pretty big gap in the evidence. The general strategy follows a 3-stage model. The goal is to build a strong, stable therapeutic alliance for long-term care. But here's the catch, and it's a big one. There are very, very few clinical trials done specifically on bipolar II. What does that mean? It means most of the treatment guidelines we have are basically borrowed or extrapolated from research on bipolar I. All right, so let's dig into the specifics of pharmacotherapy. We'll look at what the current evidence actually supports, and we'll start with how to manage acute episodes. So when someone is in an acute hypomanic state, the absolute first step is do no harm. That means getting rid of any potential triggers, things like antidepressants or stimulants. But for depression, and remember, that's where patients spend over 80% of their symptomatic time, the focus is completely different. It's all about providing fast and effective relief. When it comes to treating that acute depression, which is really the most burdensome part of the illness, the primary tools are pretty clear. Quetiapine has solid level 1 evidence. There's also a newer FDA-approved option called lumateperone, and then there's lamotrigine. It's effective, for sure, but you have to titrate it up so slowly, over about 8 weeks, which means it's just not great for providing that quick, acute relief. This brings us to the whole controversy around antidepressants. It's a real balancing act. The big risk is that you can actually trigger hypomania or mixed state. Because of that, the guideline is crystal clear. If you're going to use an antidepressant, it absolutely must be paired with a mood stabilizer. You never, ever use it as a standalone treatment.
Okay, so once the crisis is managed, the long-term goal shifts. Now it's all about maintaining stability. And here, the evidence points to a few key players. Quetiapine is good for delaying relapse into any kind of mood episode. Lithium has been shown to reduce the total amount of time people spend with mood symptoms. And lamotrigine has strong level 2 evidence for its role in maintenance therapy.
And of course, treatment is so much more than just medication. Lifestyle interventions, especially ones that help regulate sleep-wake cycles, are absolutely critical. When we look at psychotherapy, one really stands out: interpersonal and social rhythm therapy, or IPSRT. What's so special about it? Well, it's the only one that's been specifically tested in a randomized controlled trial for bipolar II. And it's designed to directly target the disruptions to our internal clocks, which are so central to this disorder. All right, let's bring all of this together now into a clear summary and some really actionable messages for clinical practice. So to recap, there are really 4 big themes here. First, bipolar II is its own distinct condition. It's not just bipolar I light. Second, its main clinical burden is depression. Third, the incredibly high rate of both psychiatric and physical comorbidities makes management tough. And that leads to the 4th point. You absolutely need an integrated, team-based approach to care.
And this all boils down to 4 key take-home messages for clinicians. Number 1, screen aggressively. If a patient comes in with depression, you have to look for a history of hypomania. Number 2, watch the body. That means rigorously monitoring their metabolic and cardiovascular health. 3, treat the depression with agents that have solid evidence, and always avoid using antidepressants by themselves. And finally, number 4, prioritize long-term stability. That means maintenance therapy and a real focus on regulating their daily rhythms.
So that brings our review to a close, but it leaves us with a really critical question. How do we take all this knowledge and translate it into better care for our patients? The evidence couldn't be clearer about how severe and complex bipolar II is. The real challenge now is to turn that evidence into earlier recognition that can truly change and save lives.